The opioid epidemic and COVID-19 pandemic are two healthcare crises that can impact each other. Many healthcare services and treatments for people struggling with substance use disorders have been disrupted by the pandemic, even with the increased use of telebehavioral health. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hederle, Executive Speechwriter with AHA. In this episode, Marie Cleary-Fishman, Vice President of Clinical Quality at the AHA Center for Health Innovation, is joined by Dr. Holly Geyer, internal medicine practitioner at the Mayo Clinic, to discuss opioid stewardship and the resources the AHA has developed to offer guidance and information to hospitals and health systems on how they can partner with patients, clinicians, and communities to address the opioid epidemic.
Well, welcome, Dr. Geyer. It's such a pleasure to have you with us today talking about this really important topic. I know you're at the Mayo Clinic in beautiful Arizona. Maybe you can tell us a little bit about your role there and your specialty in addiction medicine.
Absolutely. Thank you so much for having me. I came from a very interesting background to even get into the field of medicine. I grew up in the addiction treatment field. My parents started what was ultimately a small treatment program for addiction in Minnesota, and it grew into 800 inpatient clients. And so over the years, I grew up hearing these stories about addiction and the power it has over families, over patients, over every element of society. And I really learned from that no one is immune from this epidemic. We had people that came off the streets into this program, and we had senators' children. It was impacting everyone. And so that was really probably one of my biggest drivers to go into the field of medicine, to better understand what role I might be able to play, hopefully in a solution of some kind. I went through internal medicine and then ultimately became subspecialized in addiction medicine. I've been with Mayo Clinic now for over a decade and love it here. I help run with my administrative partner something called the Opioid Stewardship program for Mayo Clinic here in Arizona. I also serve on the enterprise committees. We help set the standards for the organization, really related to opioid stewardship, to pain management, and to elements that keep our patients safe. This has been going on for just a couple of years, and I would say the nidus for our program starting was recognizing the deleterious effects on society, on our patient population at Mayo Clinic in about 2016, when the opioid epidemic was really starting to make headlines and become very apparent in society. And so our primary focus as our group has been the creation of functional, evidence-based, and empowering tools that are going to help provide and facilitate safe opioid prescribing and administration practices at our institution. We've helped through a variety of ways to kind of broaden these efforts to be bigger than us. And that involves becoming part of national groups, advocating at organizations like this, and bringing the message to the patients themselves that this impacts everyone and it's everyone's responsibilities. We're often asked, how do you do this? Where do you begin tackling an epidemic? And we asked the same question very early on. It's not been an easy road, but it's really taken a village approach, developing enterprise workflows and protocols and tools and online modules for training. We've given grand rounds presentations. We've built division and department educational tools. We've even built patient tools that are specific in languages that might help them better understand. We've created videos. And then we've done public advocacy seminars directly to the patient population. Clearly bringing this back outside of ourselves means making sure that our local government officials are aware of what's important from a patient perspective and from a provider perspective. And so I've sat on a number of state committees, as have my colleagues addressing the crisis. I think we've even had some team members testifying in DC. It's been multifactorial. It's been a global effort on the part of our organization, but we've seen some amazing outcomes from it. And that's why I've become such a big advocate for the topic. So I can't tell you enough how much I appreciate that the American Hospital Association is taking this issue on in such a broad scale spectrum.
Well, thank you, Dr. Geyer. That's amazing work, and we really appreciate your work in it. I think that your comment about this touches everyone. Doesn't matter who you are or what your station is in life. This can touch us all, and it does take a village. So I love the fact that you've pointed those things out, and I really appreciate that. You mentioned this concept of opioid stewardship, and that's really emerging as a significant priority over this past year. Can you tell us a little bit about what that is and help us understand the importance of that in this whole area?
Yeah, great question. Um, I like to think of opioid stewardship as a verb and a noun. You may not find it in the dictionary under there, but it really is more than just a program. It's a mentality. It's an approach to living for the patient, and I think it's an approach to practicing medicine for those of us in healthcare. At the end of the day, it means using resources wisely. That when we're giving opioids, it's to the right patient, for the right indication, for the right time, at the right dose. I think this epidemic has taught us something in a manner we didn't wish to learn it, and that's that you may have one chance to get this right. So do it right the first time. I think some of the key components to opioid stewardship means that we're striking a balance between individualizing patient care, and that's a hot topic in our world, right? We're looking at their risk factors for having an overdose or secondary complications, and what is the indication for giving it in the first place? Do different pathologies warrant different types of treatments? More than likely. So individualizing that healthcare along with standardizing it, because we as providers are going to see a plethora of different pathologies on a daily basis. And there's no way that you're going to be able to individualize every sort of, sub categorization of disease with a unique type of opioid prescribing philosophy. We need department-specific guidelines and disease-specific guidelines. So how does one put this all together in kind of a nice rubric that makes sense for the daily prescribing to keep your program and your workplace functional, but keep your patients healthy? It can be a bit of a challenge, but I think we're going to have some future podcasts that will hopefully help address and demystify this.
Yeah, you really said some magic words there, and that idea of living for the patient, that really resonates with me. We have an initiative and a social movement we're working on, which is age friendly. And one of our key foci is the what matters. And so many times, we don't stop to ask the patient, what do they want in their lives? What really makes them happy and what makes them feel they're living their best life? And so I love the fact that you talked about living for the patient. I think that's so very important in everything, every aspect of healthcare, but really in this area of opioids.
Absolutely. We had done an interesting study literally a couple of months ago, and we took patients from 2019 through 2020, and we identified those that were non-surgical who were prescribed opioids at the time of their discharge from a hospital setting. And we looked at these variety of indications for which those opioids were prescribed and how many opioids about 3 or 4 weeks later they still had in their cabinets. And 30% of all these patients had barely touched their opioid prescriptions. They didn't want them, but they didn't know what to do with them. They're sitting in cabinets waiting for 12-year-olds to access at the next party down the street.
Yeah. Yeah. Wow. That's really interesting information. And I think that's so true. And so much of that is probably because we don't drive back to that goal. What is the person trying to do, and what role does pain control play in that recovery? That's amazing. You mentioned some key issues that have really been highlighted in the news lately, and that is this overdose rate, and particularly the rate that we've seen in 2020. In fact, the CDC announced last year that we saw the highest drug-related overdose deaths in U.S. history. That's unbelievable, and something that as a country we really have to tackle. Can you talk to us a little bit about those numbers and help us understand what's happening?
Yeah, Marie, they're humbling.
Yeah.
They go to show the incredible importance of prevention in our industry. My goodness, well, once the problem or the pathology develops, then it can escape the effects of even what we've seen as mass mobilized interventions on behalf of society that we've attempted to mount this past decade. The truth is that despite all of our broad campaigns on opioid stewardship, literally hundreds of state laws that have been passed, financial interventions that could equate honestly to the GDP of a small country in some cases, we're continuing to lose the war on drugs. It's just staggering. We saw that drug overdose deaths between May of 2019 to May of 2020 were higher than we've seen in the past. These numbers are going up independent of COVID-19. There were 81,000 drug-related deaths in that time period. And what we've seen in the numbers is that of those that are opioid, usually about 60 to 70% of the time, from what we can estimate, the vast majority of those are from synthetic opioids. So when we think of synthetic opioids, that leads us to think that this is stuff being laced on the streets, right? These are chemical labs made overseas being shipped to the United States, fentanyl being probably the biggest one. And why are people getting these drugs? Well, this is where healthcare comes into play. It's more than likely, according to the data, that they were started on an opioid in a hospital, in an outpatient practice setting, no longer had access to that opioid, and then were driven to the streets to meet cravings or needs. It's very scary. And then, of course, once they become prevalent on the streets, that opens up opportunity for illicit use for people that didn't come from a healthcare setting, and the cycle perpetuates. So I see a lot of contributors to this. There's no one right answer to these numbers, Marie, but if we break it down by categories, many practices, from my opinion, have really met the bare minimum standards when it comes to opioid stewardship. They either limit their interventions strictly to state laws, but don't try and go above and beyond or individualize it to their practice. Many providers just make a personal decision to prescribe less. I'm done writing opioids if this is as restrictive as it's going to be in my state, and kind of throw their hands in the air. And the reality is that their patients that were now dependent on these opioids will find it from another source. And that might be on Park Avenue, 7 blocks away at 2 a.m.
Right.
And then what we've also seen is that some institutions are creating policies that are driving patients towards alternative sources. So the institutions themselves make opioid prescribing so onerous for the providers, or very challenging, at least, to the point that providers feel locked into limiting what they can give and not necessarily individualizing that care. All of those things are very challenging. Another thing I think that's contributed is that we're not making these changes easy to integrate into practice. Opioid stewardship is a comprehensive list of interventions that a singular practice can undertake to really curb the epidemic. But it's not easy if you don't know what sources to go to for your answers. For many of these organizations, there's a lack of evidence base for the changes they make. They'll form a working group of a couple of people and say, well, no more prescriptions beyond 3 days. Does that work for everyone? Is that appropriate? Or if they create good evidence-based changes, there's a lack of communication on them. So if it's not disseminated, it's not in practice. Worse yet, and we saw this very early on at Mayo, if we're not educating our patients on these changes, it can create a hassle for prescribers. We actually had to create a document telling our patients why these changes were being made and how it was to their benefit. Of course, if you've been given opioids for a long time and we start to de-escalate you because your morphine mill equivalence is very, very high, you're going to have questions, and legitimate ones. It's key, and these can be very long conversations for providers that they don't have time for in their practice. So institutional support to facilitate those is so key.
Well, I was just gonna bring that up in that when I think about individual practices, and there's a lot of independent physicians still out there trying to manage their patients and their practices that aren't part of a large healthcare system, that might not have some of the support that comes from being part of a healthcare system. So when you talk about opioid stewardship and the benefits, can you kind of talk about the differences in practice size and how somebody might even do that independently? It seems like it would be such a hard thing to do without the benefit of some support.
We've recognized early on, opioid-related complications are no respecter of persons. It's really a responsibility that we all own, whether you're a single practice individual or you work at the highest level of an organization as a CEO. This responsibility does lie on our shoulders in the medical industry. And so we each play that key role, independent of whether it's an administrative position, a patient provider position, nursing staff, even PT. To make sure that there is a degree of opioid stewardship involved in our daily practice. The nice thing is that a program can really be based on the philosophy of ensuring safe prescribing. And with that, if you're in a small organization, you might need a lesser degree of rules or organizational structure to facilitate that. You can really tailor this to the size of your group. So from my perspective, we've seen across our community, small 3-physician family practices being able to do this well as multi-site healthcare chains like Mayo Clinic or some of the other larger ones out there. It's really keeping in line with those key concepts of having prescribing rules, educating your patients, and keep following prescribing metrics.
That's important, those prescribing metrics. I think that that's really really something that, unless we have that data, it's hard to really change what we're doing, right, based on evidence and based on seeing that. So that's a great point to make. I know this is a question outside of our discussion just a little bit, but I think one of the things that I hear frequently is the role of alternative care and alternative treatments for pain management and helping patients to move either with the opioids or from opioids. What kind of a role do you see for alternative kinds of care in dealing with or preventing, I guess, the opioid epidemic or opioid dependence?
Absolutely huge. One of the things we integrated very early on with our organization was the philosophy that if you're getting an opioid, it's paired with either a non-pharmacological or non-opioid type of pain medication at the same time. So I know that JACO, CMS, and other organizations do have regulations as to how one uses opioids, typically off a pain scale. I'm sure all of us are very familiar with the limitations of current pain scales, not necessarily targeting to functionality, which really should be our goal, but using numbers as our guide. Not that there isn't a small role for those, but we're in desperate need of remodeling this approach.
Yeah.
But as we're looking towards this remodel, things that are key is make sure if your patient is receiving an opioid that you've got an alternative plan such as Tylenol or NSAIDs as the first line approach, especially if it's an acute pain process to manage that situation. And then of course, non-pharmacologic stuff is growing and certainly paid for in many cases like physical therapy, occupational therapy, even stuff like Tai Chi and yoga has some data to it.
Yeah.
So please explore and offer to your patients if available.
Definitely. I think that's fabulous advice. And I think you're right about those pain scales. I have a personal experience of having an old country Irish farmer for a dad whose perception and his definition of pain is nothing like what you or I might think of pain as. So, he can be really, really hurt and he doesn't have any pain in his definition. So it taught me long ago after he fell from a roof to actually understand what the person's perception was and how they defined pain. And it was a good lesson that stuck with me for my whole clinical practice. So really important point about those pain scales. This is all amazing information, Dr. Geyer. Really, I find this topic so important, and it's so important to really the future of our nation and how we move forward as a healthy nation. What are some of the resources that others can look to in the future or to help so that people can help themselves and to help our nation move forward in this super important area?
I'll be honest, Marie, until the American Hospital Association stood up to the plate, there was a huge deficit on this topic. There were, singular reports here and there in the literature on how it was done. I know Mayo Clinic put one out, but never to the point that it was comprehensive enough to take a package and say, here's a step-by-step guide. So when you guys came out with your American Hospital Association Stem the Tide Opioid Stewardship Implementation Guide, and then the partner toolkit that came with it, my heart was overjoyed. I had the privilege of working on the working group with this, and you had some brilliant minds on there that took the best of the best from their organization to help build this. I found these to be resources that any size organization can use as really this step-by-step guide to engaging in opioid stewardship. I'm talking single practices and enterprise level. Like I said, they're drafted by experts in the field of opioid stewardship. They've got some amazing case examples in there and a lot of resources to help drive home the content. So gosh, I would encourage everyone visiting the HA website to download these. And I've seen this personally, but you guys have been committed to seeing that these concepts make it in the hands of every healthcare organization in the US. You've got lots of educational venues planned to really get these knowledge bases out there to the public, to healthcare. And so I think today is the podcast that we're hosting is just going to be one of a couple in the series helping address this. And I look forward as we talk about some of the integrative components that we're going to be able to talk individuals through step by step. You know, what are critical stewardship practices? How do you form your team with the right members? How do you engage the patient in stewardship? And what are the key metrics? That's a tough one. So thank you guys for being proponents of this topic. It couldn't be more important.
Well, Dr. Geyer, thank you so much. And I appreciate those kind words for the American Hospital Association. We are committed to moving this forward and to helping our nation, but we do it with members such as yourself and clinicians that are so committed to it as well. It's a partnership, and we so much appreciate your time and all of the great information that you shared with us today. It was really a pleasure to talk to you. Thank you so much.